Okay, good, very good. Okay, so before the break, we looked at systematic reviews, literature reviews as a topic. Now I want to move to meta-analysis. And as we pointed out earlier, meta-analysis is not the same as a structured systematic literature review, although you'll often see meta-analyses in systematic literature reviews. Meta-analysis is a statistical procedure to combine results from different studies. This combination may produce a stronger conclusion that can be provided by any one study. You want to use meta-analysis most often when there are not definitive studies on a topic, and the non-definitive studies may be in some disagreement. So you may have 10 RCTs, and 4 of them are favor technology A, and 4 of them favor technology B, and 2 of them are equivocal. So what do? Well, oftentimes, under certain conditions, you can combine those in a meta-analysis. All right, what are the purposes? Well, for one thing, when you do a meta-analysis, you're going to have systematic organization of the evidence, which right there is a good step. It does increase the statistical power for primary endpoints and can provide some general applicability of findings in some cases. Main thing is to resolve uncertainty when reports disagree. It provides quantitative estimates of effects in the form of an effect size or an odds ratio. It may even answer some questions that weren't posed at the beginning of the trials and identify its needs in planning for major trials. So meta-analysis can have many purposes. I guess the main one, though, is to increase the statistical power for primary endpoints. Well, here's an example of one. And there are many examples, of course. And this one is for statins versus either placebo or no statin. And the outcome of interest is all-cause mortality. So that's what this meta-analysis is about. Let's look at some key parts of it. And when we're done with this slide, everyone will be an expert. So the outcome, of course, is all-cause mortality. And what you have here, 18 trials, 18 studies here, 18 studies. And you can see that they're all of various sizes. So this one had, almost 9,000 patients, 4,400 plus 4,400. This one had 10,000 patients in total, and the number of events. So the group that got statins, for example, in this one, 460 people got statins, 459 got the control. This group only 1 event, and this one had 8 events, but it's a pretty small study. In any case, you have on the right side here, the vertical line represents the odd ratio of 1. So anything to the right of the odds ratio here favors the control group. Any point estimates to the left favor the statin. And in general, well, you've got some on both sides, I guess. I guess most of them tend to fall a little bit to the left of 1, but they're all pretty close to 1. So that's how this vertical line, this is the odds ratio. An odds ratio of 1 means no difference. Then you have this interesting aspect of weight. So it's interesting that of all these 18 trials, they're all assigned a weight, and the weight adds up to 100%. So for example, this large trial, 31, has a weighting of 31.5. This very small trial had 0.2, very small weight. When we talk about the weighting, the relative weights of all the various trials, why do some get more weight than others? Here's why. It's based on their precision. Because in precision, more precision means, oh, this is more important, we give it more weight. Precision is it's a function of 2 things. The sample size, bigger sample size tends to make something have more weight, plus the inverse of variance, which means what's the spread of data? So a real strong study has not only a large sample size, 1,000, 2,000, 10,000 patients, but the data in those studies are very narrow in the outcome. It's not the results are spread all over, low endpoint, high endpoint. It's narrow, it's precise. The variance is low. We give that a stronger weight. On the other side, if you have a study that very small sample size, only 100 patients, small, little statistical significance or limited, and the outcomes are spread all over, the variance is very high, we don't give that a large weight. So that's what the weighting is about here. All adds up to 100%. And then when you continue here, you get a point estimate at the bottom. So before I do that, let's remind ourselves, for example, this very small study here, there's the point estimate. I hope you can see it. It favors statins, but because the sample size is so small, this horizontal line is the 95% confidence interval. The study is very small. It had a lot of variance, and so the 95% confidence was so big that guess what? It's actually very close to 1.0. Here's which was statistically significant, but not by much. Okay, here's a study that's large. It's got 6,000 patients. Its point estimate is just to the right, favoring control, but the confidence interval, even though the 95% confidence interval is there, it's narrow. It does cross 1, so that one study doesn't give you a definitive answer either. So when you see long horizontal lines, that's a very wide confidence interval, not so good. Narrow lines is narrow confidence interval, that's better, but every time a confidence interval crosses 1, it's a non-definitive study. You can't find a statistically significant difference between the groups. What does the meta-analysis do? The meta-analysis combines all these, and I know it's hard to see, into a single net treatment effect. And this treatment effect, obviously, is very narrow because now it has a lot of patients. It's got, 85,000 patients almost. Yeah, it's got 85,000 patients all told. So the confidence interval is very narrow. And where's the point estimate? Ooh, the point estimate is 0.92, which favors a statin, and the 95% confidence interval is between 0.87 and 0.98. So technically, it's statistically significant, very large net sample size, and that's how you would read the meta-analysis. If you look at any one study and wanted to depend on any one or two studies, you couldn't because all these studies are in conflict or non-definitive. The meta-analysis gets you to this point. There's the full 100% weight. There's the 95% confidence interval with about 85,000 patients. And here's the difference in events. Look, statins, 1,774 events, which is less than 1,924 events. So that kind of makes sense. That's how meta-analyses work. Again, in HTA, we typically don't run clinical trials, but we collect the data from all the clinical trials, and we may have to do our own meta-analysis. Sometimes the literature already has a meta-analysis, and then you can look at those as well. So that's kind of how they work. That's how they work. It's a very, very important tool. Now, keep in mind this.
Excuse me.
Yes, of course.
Just one point that I want to address is that the heterogeneity is really important in the meta-analysis. Heterogeneity is 0, that means all studies, they have the same population. Heterogeneity, which is part of the meta-analysis. It's really important to look into it because normally if the heterogeneity is 75 or more, it's not recommended to do a meta-analysis. That means you're comparing oranges to apples. But heterogeneity with 0, this is actually a plus for this meta-analysis.
Yeah, thank you for bringing that up. I normally don't get into heterogeneity so much, and there's random effects models and non-random effects models and so forth. Yeah. When you do a meta-analysis, we'll go back here. When you talk about organizing the evidence and so forth, one of the things is when you do a meta-analysis, you've got to ask yourself, are these populations close enough? So they might have, all these trials might involve statin versus placebo, but some of them were younger people, some of them were just men, some of them were older people, some of them were people that also had diabetes, you know. So heterogeneity refers to differences across the studies, and the more heterogeneous the studies are, the less likely it is that you're going to want to combine them in a meta-analysis. The more homogeneous they are, the more likely it is, yeah, we can reasonably combine these into a study. Thank you for bringing that. I usually don't, but thank you for bringing that up. Very good. Okay.
Can I add a point too?
Yes.
Regarding the data here? So I would also say that there's time bias here because you can see clearly that some of the older studies, maybe the standard of care itself had an impact on the outcome. So
Nicely observed.
yeah.
I usually don't do it. Look, 1994, 2019, right? So when we talk about heterogeneity, one source of heterogeneity may be the passage of time may have changed something about the patient populations, something about how the drug was delivered, maybe even how the data were collected. So over time, you've got to be concerned about that. Thank you for that. And so,
Sorry.
oh, you never have to say sorry.
Just on the, also the final results.
Yes.
So when you look at the final results here, it's 0.92, and then the confidence interval is just statistically significant.
0.98.
0.98. So
It's statistically significant.
True, but a question might be whether this raises about an issue of uncertainty, because when you look at the major studies, so for example, I can't quite see from here, I think it's ALL-HAT 2002, that
Yeah.
accounted for 30% of the overall weight.
As it should.
As it should,
Because of its strong precision.
So I'm just wondering whether this, you would take away or you run away with the idea that statins definitely reduce all-cause mortality, given the fact that the point estimate isn't that far away from the larger study, which is almost 1, or it is 1. Yes, it may be statistically significant, but does it raise concerns around maybe noise around statistics and so on and so forth?
Okay, it's a good point. What meta-analysis is designed to do is to basically smooth out uncertainties across studies. Some studies may be slightly biased in this direction, some biased in this direction. The idea behind combining, in this case, 18 studies, is that you're smoothing out any kind of potential random differences and some biases in theory at least. Now, a statistician is going to say, you a priori set your p-values, right, and did all that work, and by definition, this is statistically significant. They don't start saying, well, it's trending towards this or it's trending towards this. By definition, if you set out your statistics a priori as we did here, as we're done here, it is statistically significant. Now, another layer of subtlety here, and I'm not a cardiologist, so I'm not pretending that I know a lot about statins. I will say this, when you're looking at what might be small treatment effects, okay, if you apply small but significant, clinically and statistically significant treatment effects over a very, very large population, which is how statins are used, you're going to save some lives. Okay? You give statins to 1 million people, and if the treatment effect is even small, you're going to still save hundreds or thousands of lives there because the patient population is so big. So there's still plenty of benefit to be gained there. Yes?
I just also want to comment that they do meta-analysis for side effects.
Oh, of course. Oh, yeah.
And if you do for efficacy, you don't consider side effect. So you do this separate and this separate.
Yes.
And this is why we need to balance within the modeling during the HTA assessment. So
Well, actually, this particular meta-analysis was part of a much larger study. And this one meta-analysis chart was one of many. This one happened to be an all-cause mortality. So I choose that as an example. There are several others about different outcomes as well. So that was something that they did think about as well. It's not just about the all-cause mortality, maybe other things too. Point well taken. Okay, any other great insights about meta-analysis? This is good. Heterogeneity treatment effects. People usually don't mention that. That's good. Okay. All right. Okay. Now, meta-analysis has its limitations. Keep that in mind. Okay. First of all, the primary studies that you use may have some publication bias. Maybe not all the studies got into the published literature. So there may be a little bias there. When you selected your studies, careful about how you decide to select them ahead of time. Make sure that is transparent and unbiased and objective. Don't say, oh, it shows the 10 studies based on our inclusion-exclusion criteria, but I don't really like this one. Oh, and you forgot this one from my favorite hospital. You know, you can't do that. The primary studies themselves may have been of poor quality. So when you're picking the RCTs ahead of time, your inclusion criteria and exclusion criteria might have said, we're only looking for our individual RCTs that have a high quality rating themselves. So each RCT might say, we're going to only include those with a minimal bias. So you might have already set the bar high for those. Unexplained heterogeneity, otherwise insufficient comparability. That's how I usually get the heterogeneity point. There's some heterogeneity there that you might not have known about. Or biased interpretation of findings. You might have done the meta-analysis, and whoever's writing up the study report had a bias. So meta-analysis, like any other study, is subject to certain potential biases or other weaknesses. So we always have to keep that in mind. Okay. Now that you're an expert in meta-analysis, let's talk briefly about network meta-analysis. What is a network meta-analysis? Well, it's a type of meta-analysis in which multiple alternative interventions are compared when there are limited or no available direct head-to-head trials of those interventions. What does this allow? Well, it enables integration of data from available direct trials and from indirect comparisons across trials based on a common comparator. That could be a placebo or standard of care, whatever the comparator may be. Another name for these are multiple treatment or mixed treatment comparisons, meta-analyses. What do they look like? So data from available direct trials, including indirect comparisons. Direct and indirect comparisons. Here's what they look like. Here's what they look like. Here's a network of meta-analysis. And what we wanted to do here is we wanted to compare A versus C. What do we know about A versus C? What do we know? Well, we start with whatever direct evidence we can find in the literature. Okay? And we actually have some A versus C. We have some of that. That's good. That's a direct comparison. But that's not enough. We also see that there's indirect evidence. We've got that, and in the other studies, we've got A versus B and B versus C. So the common comparator there is obviously B, right? So that's the indirect comparison evidence. So of course, we're going to keep this. What else do we do? Well, we take that indirect evidence from across the RCTs, and with an indirect comparison, get from here A versus B, B versus C, indirectly compare A versus C, which we've done there. And then for the final combining direct evidence, we combine the direct evidence with the indirect evidence to get A versus C. So that's a very basic kind of description of how these work. It takes whatever you've got in the literature. If you've got the direct comparison, good. But if you have some indirect comparisons, you can get that too, if there's a common comparator. Here's what something like that might look like. This is a network meta-analysis of 7 different therapies. So you had A, B, C, here you go, A, B, C, D, E, F, G therapies, and 3 different outcomes. Here's outcome 1, outcome 2, outcome 3. Let's take a look. So for outcome 1, what do you see there? What do you see there? Well, you have multiple comparisons here. You have A versus placebo. You also have A versus C, B versus placebo. Wherever you see a line is a direct comparison. The thicker lines refer to either the number of studies or the strength of studies. It depends how you look at this. Let's say the number of studies. If you've got a lot of A versus placebo studies, a lot of D versus placebo studies. If I want to compare A to D, well, I don't have any direct A to D. Nothing direct, but they're both compared to placebo, so there's an indirect comparison. If I want to compare A to, let's say, E, again, nothing direct there, but they've both been compared to placebo. So you see how that works. And then for this outcome number 2, you only had 5 of the drugs, 5 of the 7 therapies, and limited direct comparisons. But if I want to compare A to E, they're both against placebo. Now D to G, direct. I've got direct D versus G. And so, plus I've got D to placebo and placebo to E. So I can use that indirect evidence as well. So that's basically how these things work. Direct evidence when you've got it, plus indirect evidence when you can get it, indirect evidence with a common comparator. That's basically what network meta-analysis is. I know this is a very high level. Questions, comments about this? I will say this. Oh, maybe you're going to say what I'm going to say. Go ahead.
Just comment because some of it looks so complicated, but it's very useful. And some of the evidence, especially in cancer, because there is a lot of oral compared to IV, but we don't have compare oral to oral. And this is how the FDA actually started to collect from the indirect evidence. So it could be very complicated, not applicable to all diseases, but I agree. It depends on your data and your studies, what kind exactly studies you have. But
Right.
it is very useful in cancer, for example. I just want to give an example
Sure.
because of my experience.
Also, inherently, you would probably say that an indirect comparison is inherently less strong than a direct comparison. Even if you have a common comparator, you're always thinking, there might be some differences in the studies, the population or something, so I'm not going to give quite as much weight maybe to the indirect comparison as I will to the direct. But in the absence of a lot of evidence, you may want to rely or use the indirect comparison. That's what a network meta-analysis does. Okay? We're experts now in network meta-analysis. Excellent. Okay. All right, let's talk a little bit about modeling. You know, modeling is another secondary method because it relies largely on existing data. Now, sometimes you can get additional data, but it's a synthesis or integrative method because it says, what data do we have to try to model or represent reality? So, modeling, an analytical technique to simulate or represent real processes involving decisions and outcomes, for choosing among alternative healthcare interventions in a particular patient population. Modeling accounts for uncertainties in the form of probabilities usually, that each decision will result in a particular outcome or health state and the value associated with it. There are all kinds of modeling approaches, and we could spend forever on those. But some that you might have seen or heard of, or even done yourselves, decision analysis or decision tree, Markov chains, MCDA, multi-criteria decision analysis, Monte Carlo simulations. There are even simulations of disease processes, healthcare interventions, and systems. By the way, AI is really taking off on modeling biological processes, you know, the body at a cellular level, molecular level. It's really quite impressive. How useful it is yet, I don't know, but it's very impressive how it's done technically. So, out of all these kinds of modeling, again, why do you model? You do a model because you don't have a study or an analysis that sufficiently represents reality, or you want to look at different ways of approaching a problem and model what they might yield or what the outcomes might be, trying to represent reality or potential reality or options. So this is a straightforward decision tree or decision analysis model. This happens to be a cost per treatment model. The arithmetic is shown there. But basically, this is how you would set up a decision tree, or maybe it's like an upside down tree. So you have a certain patient population, and you can compare drug X to drug Y, right? Drug X is 1,000, drug Y is 2,000. So right away, drug Y is twice as expensive as drug Y is twice as expensive as drug X. But for each of them, you have to model what could happen, right? What are the alternatives? What could happen? Well, for each of them, for drug X and for drug Y, there's a possibility of an adverse effect. The possibility here is 10% of the time when people get drug X, they have an adverse effect. And by the way, to treat the adverse effect costs another $500. The other 90% have no adverse effect, so no additional payment. Drug Y, the adverse effect probability is only 0.05. Less than that, also costs $500 to fix, and 95% of the time, no adverse effect. But it goes further. Let's say you had an adverse effect, those 10% of 500, 90% of the time they get better. 10% of the time they still don't get better, and that gets really expensive. These people that took drug X, they had an adverse effect, they did not respond, that's another $5,000. So that looks pretty big, and then some had no adverse effect, and so forth. So The same thing with drug Y. Drug Y, adverse effect 500 at 5%. 95% of these people get better, but 5% get worse, and that's another $5,000, and so forth. So even here where they have no adverse effect, there may be some failure where you get another $5,000. So what happens? What happens? Well, you say, what's the weighted average cost? These people, a chance of 135, 65, these can be expensive, and so forth. So you get finally, through all the arithmetic here, you get a weighted average cost for these possibilities. So if your patient population, you can end up at 1, 2, 3, 4, 5, 6. There are 8 ways that you can end up. Half of you get drug X, half get drug Y, but for each of those, you can end up at 4 different places. And finally, when you do the arithmetic, it looks like this, that when the expected average cost per treatment here, drug X, remember that cost $1,000, ends up being $1,550 average cost. Drug Y, which costs $2,000, still costs more, $2,275. So that's basically a real straightforward example of a decision tree. What did you do? You said, well, we're going to have to look at 2 different drugs. What could happen? What are the pathways that could be followed? Well, as it turns out, patients are going to end up in one of these 8 places. What does it cost to get there? And what's the average treatment cost for those people? And then ultimately, when you account for the initial cost of the drug and who gets adverse effects and who doesn't, who responds to the treatment for that, who doesn't, how much does that cost, you end up with this finding. So that's just a quick example of a decision analysis model. Yes?
I just want to add, remember that question about the adverse effect?
Yep.
We considered within the model to the cost and
Ah,
the distribution.
yeah.
So
Good point. That's a good example. Yes. So if you want to check the arithmetic, well, by the way, as I said earlier, after today, everybody gets a copy of the whole presentation. So if you want to look at details, good. Okay, one of my favorites, Markov modeling. An entirely different way to think about healthcare technology. Markov modeling, named after a man named Markov, represents changes from one health state to another, such as different stages of disease and death. It's very useful for representing patient or population experience when health states change over time. So Markov is a way of modeling effects over time and changes in patient status. Some or all of the health states may recur, and you assign probabilities to these transitions. Very interesting. We're assuming that every patient is always in one of a set of mutually exclusive health states. There's a set of allowable probabilities for moving from one state to another, and so forth. You can even assign patient utilities to being in those health states. Let's just take a look at how this thing works. So here's an interesting Markov model, basic approach. And in this case, for some disease, you could be in one of 4 health states. Well, you could be normal and not really have it. You could be asymptomatic, have asymptomatic disease, or you could have progressive disease, or you can not survive, you can die. There are 4 things you could be with regard to some disease. Pick out a cancer, diabetes, hypertension, whatever it is. What does Markov do? It's got 4 disease states. Here's what it does. It says, well, after some period, let's call it a year. After a year, if you started as normal, you might still be normal. Or if you started as normal, you went to asymptomatic. Or you started as normal, you started as asymptomatic and you stayed as asymptomatic. Or you started as asymptomatic and you got back better, you went back to normal. That'd be nice. Or you started as asymptomatic and you went to progressive a year later. Or you started as progressive and a year later you're still progressive. Or a year later you went from progressive to death. Or you might have started an asymptomatic and went to death after 1 year. Or you started as normal and went to death after 1 year. And so, of course, if you're in this state, a year later, nothing changes, right? Okay? But the point is that after some period of time, again, let's call it 1 year, you may stay in a particular disease state or make a transition. That's how Markov is set up. Now, what do? Based on the literature and other input sources, you assign transition probabilities to each of these transitions, these arrows. What do I mean by that? Well, let's call them one-year transition probabilities. So if you're normal at year 0, a year later, you have a 95% chance of still being normal. Good for you. Or what about the other 5% who are normal at year 0? Oh, 4.9% change from normal to asymptomatic, and then 1 out of 1,000, for some reason, go from normal to death. 0.95 plus 0.049 plus 0.01, 1.0. Okay, let's keep going. If you started as asymptomatic in year 0, a year later, 85% chance of still being asymptomatic, but 10% of going back to normal, good for you, 4% chance of going to progressive, and 1% chance of going to death. So for each one of these, there's a transition probability. You start out year 0, you might have been in any one of these 3, not the last one, but a year later, where are you? Okay? Now, let's follow through. Let's say I've got a patient population in year 0 of 100,000 patients. As of year 0, where are these 100,000 patients? Let's say that in year 0, 75,000 of them are normal, 20,000 are asymptomatic, and the other 5,000 are progressive. That's baseline, that's year 0. After 1 year, with these probabilities of transition, where are we after 1 year? Well, after year 1, some of these people went somewhere else. 73,250 are only left because some of them went somewhere else. And this went from 20,000 to 2675, that went from 5,000 to 5650, and now 425 went into the death state. Okay? That's after 1 year with those probabilities. That's how they transitioned. What happened in the next year? Again with the same transition probabilities. This goes down a little bit, of course. This goes up a little bit, of course. This goes up, so does that. You can keep, as we say, cranking through these transition probabilities year after year after year after year. That's how this happens. And in real life, people do go from a disease state to another. Now, if you really wanted to get more complicated, you might divide these. Well, the normals, there are different kinds of normals. And some of them are 0.95, and then some of them are 0.97, and some of them are 9.91. So you could even subdivide these into patient subgroups. That gets more complicated. And for example, by age or sex or comorbidities, other health problems. So you may subdivide those if you want. And the annual transition probabilities may vary by patient subgroup. So like I said, maybe instead of 0.9 for all normals, people with this sex or this age or this comorbidity is something higher or lower. So that's how it gets complicated. Now, ask yourself, how does this work with therapies? Let's say this is the baseline. Now, this is the baseline, this is what year 1, year 2 look like. What if we introduce a new therapy? What if you say, now, for example, everybody who has detected asymptomatic gets a therapy, or everybody's got progressive, we give them a therapy. Once you've changed the therapy for them, the transition probabilities are going to change too. And then when you crank through it year after year, these numbers will look different. That's how you would introduce a therapy to a Markov model. At baseline, if you don't do anything with people, this is what happens to them. Year 0, year 1, year 2, year 3. But if you give them a therapy, the transition probabilities change. Now, why is this kind of an integrative method? Because where do you get the probabilities, right? Got to go to the literature. Now, the literature may be helpful sometimes, not helpful other times, right? And so if you don't get all those data on transition probabilities from literature, sometimes you have to put together an expert group of epidemiologists or biostatisticians or clinicians and say, okay, let's kind of come up with some of these probabilities here. And then let's take it another step, although we're not going to crank through it now. You assign costs. You assign costs to being in each one of these states. You assign costs to that introduced new therapy. Then Markov modeling gets even more complicated. But this is basically how it works. It's got to be several health states. I know this gets really complicated after a while, and this is about the limits of my own expertise in Markov, but this is basically how they work. But I hope you see how they're useful. This can be useful. Okay, Markov. Next. Let's talk about MCDA. This was raised earlier, multi-criteria decision analysis. This is another sort of integrative technique, a form of group judgment, I'll call it. MCDA. Healthcare decisions are often complex, involving trade-offs among multiple dimensions of value. What you value and I value might be different. A structured, explicit approach to these decisions using multiple criteria that represent those dimensions of value can improve the quality of decision making. And a set of techniques for this type of approach is known as MCDA. MCDA is not just about HTA. MCDA is used in all sorts of industries. What is it? It is a transparent, open, and objective method for separating decision. If you are doing an HTA and you get an expert committee to talk about the data and the evidence and what's important, you may have different preferences, or you may value, maybe one person values effectiveness more than the safety. Other persons might say, you know, I really care about the adverse events here. That's even more important to me. But what you do with MCDA is we say, put it on the table. You make explicit and transparent what you value, what criteria matter to you, and how you weight those criteria. So it also identifies and compares the criteria for any two options, or any option, I should say, from different perspectives, different people. It evaluates each option by some sort of ranking or rating or comparison of pairs of options. There are techniques for doing this. If I think I have preferences among 5 things, like how do I really rate them? Is 4 more important than 2? Is 2 more important than 3? But is 1 more important than 4 than 5? So there are techniques called ranking, rating, or something called conjoint analysis and analytic hierarchy, and so other techniques. It can reduce cognitive biases, just intuitive decision making. It makes you think through what's important here, what dimensions of value matter to me, and how relatively important are those dimensions. It can avoid imposing my preferences over your preferences. We put all of our preferences on the table and look at them objectively. In HTA, how do you use this stuff? Well, we can use MCDA for setting priorities, for making coverage or delisting of drugs and other technologies, for kind of sorting through patient preferences for different endpoints and outcomes. Like I said, effectiveness, safety, survival, quality of life, functional status, who knows? If you want to kind of get into this more, and we're not going to do an example, but here are the main steps. But I do want you to notice that it is an objective process. A priori, ahead of time, say, these are the steps we're going to take. So what is your problem in the first place? What are the criteria that matter to you? What are the criteria that matter to, is it safety, is it effectiveness, is it cost? Is it patient preferences? Is it some kind of legal concern or ethical concern? And then what are the weights of those? You weight the criteria accordingly. Then you say, then you measure. Well, how are we doing on those criteria? You score them, provide a score. You add up the scores in an aggregate. Then you got to say, well, there's some uncertainty here. I'm not so sure about this. It's almost like confidence intervals. And then you use this important information to support decision making. So again, without going into a lot of detail, you see these steps. Think about how walking through these steps as a group is better and more explicit than just saying, all right, let's talk around it around the table. And well, that guy Cliff, he talks too much. He always dominates the conversation. So-and-so, she really knows what she's talking about, but she's too quiet. She doesn't say anything. This person doesn't even pay attention. This person keeps, so all that variation, you're being much more objective and transparent about it. This is a more fair way to come up with assessing relative value here. MCDA. So again, you don't have to be an expert in it, but you do want to recognize the term and how it is used. MCDA. Yes?
So something a bit confusing about NCDA, I can't really understand how it fits into HTA. Is it supposed to be like something we develop for a disease area, or like
a whole concept on how we're going to approach evaluating a medication, or is it something that's going to be developed per se for that specific drug? So is it like a template of the MCDA that we can use in our decision-making process in general?
Right.
Because it's a lengthy process. I mean, I don't think this
Can
is
be.
something you can continue doing like for every
time.
drug or disease.
Right.
But then the value is very different, of course, for every single disease also.
Right. So I'm glad you asked that question. There's no one way to use it in HTA. The one that comes to mind for me usually is priority setting. And that is, okay, we're very busy in our formulary. We have all these drugs coming in. We have budgetary constraints. Somebody else is telling us to hurry up. We can't assess all the drugs we want to assess. We don't have the time. We don't have the resources. How do we decide which ones to assess? So you might use MCDA to say, okay, listen, how do we narrow these things out? Well, what are the important criteria? Well, I think the most important criterion is the potential budget impact. So that's, to me, the most important. Somebody else is going to say, well, I don't know. Budget impact's important, but I would rank that third. To me, the most important thing is demonstrated efficacy. And someone else is going to say, I know, but the studies out there are pretty bad, they're pretty weak. I'm really concerned about looking to see where there's evidence of relative strength and weakness, and that's going to help dictate what I'm going to assess. So we all might value those criteria for assessing priorities differently. Let's put them on the table. So to me, that's how I would kind of use that. You could, yeah. Oh, you did?
Yeah.
Oh, good. Oh, I got.
That's how we use it.
Oh, did? Oh, I didn't know that. I'm glad we're thinking alike. Okay, yeah, I'm interested. So, and then there's some other ways of using, even for coverage decision making, you might say, if we're going to say cover or not cover, what matters to us? Once again, budget impact, no, not by itself. Safety and efficacy, and effectiveness, reducing inequalities, embracing diversity. It could be any or all of those things.
I just want to add also, it came beyond even health and when it started.
Microphone, we should probably hand the microphone. Yeah.
And
It's on, I think, already.
actually, it's not really something they use in the HTA. But I think it's beauty that it's, they want to use it or to have it invented within the system because of the quality limitations as one single metric. While we are thinking about beyond the health benefit as a metric and think about inequality as you just stated and other elements that's really valuable and needs to be assessed within. So thank
It's a
you very
point well
much.
taken. Also, maybe you don't need to do all the steps. You know, maybe it might be enough in your case to say, let's make sure we understand the decision problem. What are the criteria that matter? And maybe that's enough to make clear what we think matters. It depends. Yes?
Yeah. As Dr. Leila mentioned, we do have a prioritization tool, including efficacy first, and then safety, and then the budget impact. My problem is, or my issue is, sometimes, especially when it comes to expensive medications, what some are doing is just a direct cost comparison, which basically doesn't actually justify the inclusion of the medication, because only the direct cost, especially when it the marginal efficacy, probably we should do a little more than direct cost comparison, because if you do the direct, you will exclude all of the indirect costs and everything. Sometimes the medication could be more expensive. However, when you think about it in the indirect way, probably you could save a lot of money, reduce hospitalization, etc.
Well, this, whether it's MCDA or something similar, the idea is we need to make clear what our criteria are. And let's kind of agree on what they are, or at least kind of understand what our differences are, rather than just saying, you keep in mind what you think is important, and I keep in mind what I think is important. So that's kind of an advantage. You don't have to do every step every time, of course not. Good. All right, now, we're going to try to cover types of economic analyses. Again, we'd spend a lot of time on this. These are some basic, I'm going to show you 5 or 6 things here. Sometimes people say, oh, you did a cost effectiveness analysis. No, you did something else. So let's make some distinctions here. Cost of illness. basically, what does diabetes cost in Saudi Arabia? How many billions of riyal? What does the thing cost? It's not cost effectiveness. It's not making comparison. Just what does this cost? 2, cost minimization analysis says, okay, I've got technology A versus technology B. If I can assume that the outcomes are about the same, all those things are about the same, give me the cheaper one. Give me the minimal cost. That's what cost CMA is, cost minimization. Sometimes that's fine. Sometimes you have 2 drugs in a given class and the price is different and you assume that the mechanism of action is close enough and the outcomes are about the same, fine. Cost effectiveness analysis, a little bit different. It weighs costs against some kind of outcome where the outcome is focused on a single natural unit. For example, cost per death averted, cost per heart attack averted, cost per lung cancer case detected, for example. So it's a cost for some natural kind of health unit. That's cost effectiveness analysis. Now, within there, we can maybe have some subcategories. Cost consequence analysis is a form of cost effectiveness analysis, but you don't do all the math. You don't do the ratio and the arithmetic. You basically say, okay, here's technology, this direct, indirect, this cost, this cost, this cost, this outcome, this outcome, this outcome. Technology B, these costs, these outcomes. You show them in an array, like a chart, but you don't do the ratios, all the arithmetic. You're just displaying the costs and displaying the consequences or the outcomes. Cost utility analysis technically is a form of cost effectiveness analysis, but cost utility is utility for an outcome, which is something like quality adjusted life years. So in practice, when people do cost per quality, they often call it cost effectiveness analysis. Well, I suppose that is a type. I usually like to say, well, that's actually a cost utility analysis. Something fairly new these days that they're calling is distributional cost effectiveness analysis. And what this recognizes is that whether something is cost effective or not depends a lot on patient subgroups. You know, cost effective for which patient population? They all have a certain healthcare, disease or healthcare condition, but the costs might be different and the outcomes might be different by subgroups. So we might call that a distributional cost effectiveness analysis. I haven't seen much of that until recently. This is a fairly recent phenomenon. CBA, cost benefit analysis, is actually, I think, the hardest to do for real, because cost benefit analysis is cost weighed against the outcomes, where outcomes are aggregated into monetary units. So you just can't say cost per heart attack averted. You have to assign a monetary value to averting the heart attack. So it's basically money in versus money out. It's hard to, especially if you're assigning a value, a monetary value to a life, for example. That can get very complicated. But the point is that these are all different. Finally, BIA is different. Budget impact basically doesn't say how effective it is. It just says if we provide this technology to our indicated patient population, it's going to cost this much to our budget. Okay? Keep in mind that budget impact and cost effectiveness analysis, they don't always agree. I think I gave the example before. So this happens to NICE all the time in the UK. NICE says, well, we did a cost utility analysis, cost per quality, and this technology falls under the threshold, and so therefore we're recommending it to the National Health Service. The National Health Service says, well, thanks very much. I know we're obliged to follow this, except that even though this technology is cost effective on a patient-by-patient basis, if we give this technology to everyone who's indicated, we're going to run out of money. So the budget impact is great. So budget impact is different. But my point is that when we talk about doing economic analyses in HTA, they're not all cost effectiveness analyses. And each one of these has a different sort of role in informing policy decisions. Let's take a couple looks at these. Oh, by the way, if you kind of wanted to simplify all these, they all have some kind of valuation and cost and then some valuation of outcomes. So cost of illness doesn't have, we don't talk about the valuation of outcomes. It's just like, what do these things cost? Cost effectiveness is cost divided by natural health units. Cost utility is cost per technically in economist terms utiles, that is in the form of qualities and so forth. Budget impact, what did the whole thing cost, and so forth. So let's take a look at a cost effectiveness ratio. This is a basic kind of example of one. It's marginal costs, marginal effectiveness. It's not absolute cost and absolute effectiveness. It's the difference between what you're doing now and something new. Okay? So we have a cost effectiveness ratio. We're comparing, A is our comparator. That's what we do all the time. And the effectiveness of A is this. And we got a new intervention, B. So it's the difference between B and A in cost divided by the difference in their effectiveness. Marginal. Change in cost, change in effectiveness. What would it look like? Well, here's an example. Our comparator, which is our standard of care, is drug A. For every 100 patients, it's going to cost this much. Total dollars, let's say, per 100 patients is 1,000. In those 1,000, we save 8 lives. And the ratio here would be 1,000 divided by 8 is 125 per patient per life saved. But that's not marginal. What we're caring about is the difference. Well, new drug A, it's really an expensive drug. You want to give that drug to 100 patients, it's going to cost you $1 million. But you save 10 lives instead of 8 lives. So $1 million divided by 10, $100,000 per life saved. So with drug A, 125 per life saved, drug B, 100,000 per life saved. What's the cost effectiveness ratio? The difference between drug A and drug B in providing it for 100 patients is 999,000. The difference in lives saved is +2, going from 8 to 10. Therefore, the incremental cost effectiveness ratio of changing from drug A, your comparator, to drug B is 499,500. If you want to move from drug A to drug B and you want to save a life, it's going to cost you this much to save one more life. Okay? Now, some countries are glad to do that. Some countries are saying, are you kidding? We can't afford to put that much money. We love people's lives. That's a lot of money to spend. Maybe we could spend our money somewhere else and save more lives. Who knows? Very difficult decision. But this is how a CEA, an incremental cost effectiveness ratio, works. That's basically how it works. Basically how it works. It's not the absolute costs and the absolute effectiveness. It's the delta, the change in cost and the change in effectiveness. Yes? Mm-hmm.
I believe, it depends on the threshold, cost effectiveness threshold.
Yeah, and we're going to get to that. Yeah, exactly. Whether you want to do this or not depends on if you have a CET, cost effectiveness threshold. Exactly. And I'm going to show you an example of that pretty soon. So that's just how it works. I don't say we should do this or not, but that's how they work. Now, let's try something else here. Cost utility ratio. Let's talk about qualities now. Quality just, remember why they're good? Because if you have cost per quality, I can compare this technology for brain cancer to this technology for hypertension, or this technology for some other condition, okay? How does this work? Again, similarly, it's a comparison. Here, the comparator standard of care is X, the new intervention is Y. Change in cost between Y and X, change in quality adjusted life years for Y and X. How would this work? Here's an example. Now, I'm going to do this on a patient-by-patient basis. Drug X, which is my standard of care, $5,000 per patient. Every single patient costs $5,000. That patient has 5 years of life left, but the utility, their utility for those life years, the quality adjusted life year is only 0.5. For these patients who get drug X, on a scale of 0 death to 1 perfect utility and perfect health, it's only 0.5. So that's not a great quality of life. And so drug X gets you 5 years, but only 0.5 utility, which is 2.5 quality adjusted life years. They're going to live for 5 more years, but the quality adjustment brings it down to 2.5. Similarly, for drug Y, This is a lot more expensive. $250,000 per patient. It does get you another life year, but aha, the utility for these 6 years is better. It's not 1, but it's 0.8, which is a better utility than 0.5. Okay? So how many qualities is that? 6 times 0.8 utility, 4.8 quality adjusted life years. So I'm getting more quality adjusted life years with drug Y, but it's pretty expensive. So you do the final calculation, cost per quality gained. So it's, again, marginal per quality gained. What do we have? Well, the delta here is what? 5,000 to 250, that's another 245,000. And the change in qualities is 2.3. To get to 2.5 to 4.8 is another 2.3. So for every 245,000, you get to buy 2.3 qualities, or the arithmetic per quality is that. So here, if you want to buy, if you're interested in buying quality adjusted life years, if you want to use drug Y instead of drug X, you spend another $107,000 to buy one more quality adjusted life year. Now, whether that's acceptable for you and your health system is another question, but that's how you get here. Once again, the format's about the same in the delta in cost and delta in the numerator, denominator. Here it's qualities, but that's how these things work. That's how they work. Questions about cost per quality? We're going to get into the threshold thing, I promise. That's how they work. Marginal, not absolute, marginal, delta. Now, I'm not a world-class economist, but when I think about cost effectiveness analyses or even cost utility analyses, I think about this thing we call the cost effectiveness plane. I'm sure many of you have seen this. And in this cost effectiveness plane, it's always helpful for me to think of problems this way. Here's our comparator. This is our current therapy right there. Our current therapy costs this much, whatever that is. This is its cost, and its effectiveness is here. So today, this is where I am with my cost and my effectiveness. Now, we introduce a new intervention, a new option. What if the option falls here? I've got a new technology. It costs more, and it's less effective? It's dominated. The economist said that's dominant. So it's dominated. So we reject it. No more work needed, right? What if it falls here? It costs less and it's more effective. So this is dominant. Cost saving. You get better outcomes for less money. It gets more complicated here and here. Well, how about here? Well, it costs more, but it's also more effective. This one, it costs less and it's less effective. So am I willing to be a little less effective if I'm saving money? Sometimes we have to look at this one too. So 4 places where the trade-off can happen. And these 2 places are where it gets complicated. Not the dominance, not the dominated. Now, let's take it a step further. Where might I be willing more adopt or reject, even within those quadrants? What do I mean? Well, what if it's there? This one costs a lot more, and it's just a little more effective, right? It's only a little more effective. Maybe I'm going to reject that. I know it's a little more effective, but it costs too much. It's not worth it. Or here. Well, this one, I have to spend a little more money, but it's a lot more effective. I'm more likely to adopt. Same thing here, same thing here. So then the question becomes, in your healthcare system, where are you going to draw that line? Where's your reject? Where does this line? What does reject mean here? What does adopt here? Or are you going to buy all these? Maybe you're going to buy all those. No matter how much it costs, for any amount of effectiveness, you'll pay for it. I doubt it. But in any case, where does the line fall for you? And this gets at the threshold thing. We'll get there. Actually, this is a depiction of the threshold, but we're going to quantify it in a minute. All right, now I'm going to pull 2 things together here. You remember, I described what cost utility analysis is. You remember this slide. Remember? Current therapy, additional therapy, new therapy, it buys you more time and more quality of life. The yellow is that's the quality that you're buying, or qualities that you're buying. Now the question becomes, how much do you want to pay for the yellow part, for the yellow sector? How much are you willing to pay to buy one more year and more quality of life, to buy an additional quality additional life year? Want to spend $1,000, $10,000, $100,000, $1 million? What are you willing to spend? And so where we at now is, here's the same quadrant, right? Here we are again, same kind of cost effectiveness plane. You remember this line. The line could fall anywhere. So for example, if maybe I'm in a poor country, and I say, or we decide, listen, if something's more than $20,000 per quality, we just can't afford it. There's an opportunity cost there. We can spend the money elsewhere to buy more qualities. Okay, and so you're saying that, well, if it comes in here, we're going to pay for it. But if it falls anywhere above the yellow line, no. Then you've got the green line. Then maybe the red line. The red line's $100,000 per quality. 100,000 quality says, I'm going to pay for anything below the red line here. Or maybe even here, by the way. That's okay with me. Where this line is drawn, if this is an approach you use, is quite controversial. Now, you may not have a threshold, a CET designated threshold, but maybe you are still thinking about your value for money. And you may be thinking, up here, I'm not sure that's how we should spend our fixed budget. So you may not have a national threshold like NICE does in the UK, but you're thinking about the trade-offs there. Now, with regard to NICE in the UK, their threshold has been somewhere, because I'm saying that they're the most controversial, they've had it somewhere between 20,000 and 30,000 British pounds sterling, okay? How they got there is controversial. And by the way, it hasn't changed in a long time, so you're wondering about how useful it is. As it turns out, and there's a whole fascinating literature about this, if you actually look at expenditures in the UK and utilities and impact on gross domestic product and all these, you do all the math, the threshold there should be lower, which was really surprising a lot of people. Because the industry said, oh, 30,000 is too low. And they do the calculations, given, they've got a fixed budget, right? And opportunity costs, well, it should actually be 18,000. That surprised a lot of people. Now, I will say this, we could spend a day and talk about this too. They have given exceptions, okay? So for certain rare diseases, like diseases that are fatal to children, young children, and certain ultra-rare conditions, they don't do 20 to 30,000, they might make it 100,000 or even more. So they have flexed the diagonal there. So they've basically gone from here for ultra-rare conditions for children who are going to die, terrible things, they'll give you this. It's quite complicated, but basically they were flexible in that. Fascinating stuff. Okay, BIA. Like we pointed out a few times already today, allocating resources efficiently may not be consistent with affordability. So budget impact analysis can complement economic evaluation and inform decisions. Let's just take a look at an example. Here's the new intervention A. We're going to talk about potential budget impact. This intervention A costs, no matter who gets it, it costs $500. No matter who gets it, it costs $500. In people that are under age 45, and you're responsible in your patient population, you've got 250 people in your patient population who are indicated for this therapy. And when you do the math here, you say, aha, this times this is that. The potential budget impact is $125,000. But look at this. What's the cost per life year gained? In people aged under 45, if I give them this technology, I'm spending enough 500s to get to 200,000 to get one life year gain. Not a lifetime gain, but one life year. So if I'm spending money on this technology, I've got to spend 200,000 worth of it in these people to gain one life year. And the budget impact is 125,000. Next. In these people, a little older, technology costs the same. I've got 1,000 patients in this age group, But in these people, because of how effective it is in them, it only costs $75,000 in this spending to buy 1 life year gained. For these people, also cost the same. I've got 1,750 of those folks. That's budget impact. But it's pretty cost effective here. I only have to spend 25,000 pounds of this money to buy a life year gained. And in the elderly, same thing. It costs $500 to give it to them. I've got 2,000 people who are indicated in it, in this age group. But every time I spend money, I only have to spend 15,000 of these to buy a life year. So now we say, wow, interesting. You know, from a cost effectiveness analysis standpoint, you know, you start with these folks because this is you get more, as we say, bang for the buck, right? And less and less and less here. But now I tell you, well, this is all very interesting. However, you only have 500,000 to spend. Now what do? Budget impact, tough decision. This is the potential budget impact I've got. How am I going to spend my 500,000? Half of these people, maybe that's how you do it. Or maybe say, well, we really care about the younger people, so we're going to start with them first. There's no right answer. This is the kind of decision you face. The thing may be really cost effective, but if you don't have the money, you've got a problem. Okay? This is where budget impact crosses with cost effectiveness analysis. Anyway, this is a very nice basic example of it. Budget impact. Okay, I'm going to move quickly through a bunch of concepts here. Don't have time to cover them all. When I do a health economic study, I look for various attributes to study it to make sure, is this a good study or not a good study? Any or all of these. We can't go through them all, but I do want to say, okay, what's the comparator? What's the economic perspective? What are your outcomes? Was it efficacy or effectiveness? How did you get the data? Direct costs, indirect costs. Actually, all these are the kinds of questions you might ask about a health economic study, whether it's cost utility analysis or cost effectiveness or something else. You could ask questions about all these. Let's look at a few. Comparator. Okay, technology A is more cost effective than technology B. How'd you choose technology B? What's your comparator? Is it the standard of care? Was it placebo? Was it minimum? What was it? You got to tell me what the comparison was. If you don't, this is not a good study. Perspective. Whoa, this gets very complicated. Whose economic perspective is this? When you read an economic study, it should say, we adopted the economic perspective of society, of the national health system, of maybe the patient. What's the economic perspective? Any or all those. There's no single right answer, but for your decision making, you might have a right answer. What's your economic perspective? Maybe it's your budget, or maybe it's the national healthcare system. Direct costs. Two kinds of direct costs. The first one's obvious. What's the cost of hospitalization, of the drugs, of the surgery, whatever. Non-healthcare costs may be costs to patients. They're direct costs, but it may be the cost of the patient's time to get child care, transportation to the hospital, volunteer time, and so forth. So direct costs are two main types, direct health and direct non-health. Those are not the same thing, and those are different from indirect costs. Sometimes known as productivity costs. Lost productivity, absenteeism, early retirement. There's a cost to an employer or society of less productivity. Or that's different from impaired productivity. We call that presenteeism. You go to work, but you're not very effective. Or lost productivity due to premature mortality. A working person dies at age 34. They still could have been productive, but that's gone now. Or lost or even impaired leisure activity. Indirect costs, different from direct non-healthcare costs. Time horizon. When I look at an economic study, I want to say, okay, well, wait a minute. What's the time period that you covered here? That's important because it might affect the answer. What do I mean? Well, let's take a look at some kind of intervention. We're going to look at a 20-year timeline. We're going to look at costs here. What are the cumulative costs over time? Look like that. Maybe it's a smoking cessation program, or maybe it's cervical cancer screening. Could be anything. cumulative costs over time versus the health impact. What's going on here? I'm starting to spend money here on this program, let's say smoking cessation. But the health impact, it takes a while for it to have an impact, right? You don't get the impact on day one. So the health impact lags the costs. So the outcome doesn't happen right away. It happens on a later timeline. Here health improvement lags investment. So the determination of cost effectiveness depends on the relative accruals of costs and benefits at selected time horizons. Let's say you did your cost effectiveness analysis there at, let's say, 5 years. Well, it's going to say, hey, you spent a lot of money already, got almost no health impact. Not a good cost-effective investment. What if you did it at 10 years? Well, now we've spent a lot of money here, and we're starting to get some health impact. You're going to do your cost-effectiveness analysis there? Maybe at 15 years, what do you have? Now, at 15 years, what do you have? You spent most of your cumulative costs, and now you're finally seeing that uptick, that increase in health benefit. So when I look at a cost-effectiveness analysis, I'm going to often say, time horizon. Is there a lag time between the money in versus the outcome on the other side? Time horizon. And it's got to be long enough to capture the streams of health and economic outcomes. It could be a disease episode or patient life, even multiple generations. It may take a while for this thing to, as we say, kick in, to happen. If it's an emergency appendectomy, fine, short time horizon. I've got appendicitis, I go to the hospital, they take it out, I feel better, we're done. But if it's something else, like, as I said, a smoking cessation problem or cholesterol lowering, it takes time. Okay, if you really care about this stuff, there are a bunch of checklists you can use. Cheers is a common one, it's updated recently. I know a lot of these people are very good health economists. So they updated this a few years ago. It's a great checklist. There are many others as well. Yes?
The cheers criteria, isn't that just for what to report, or like it's not a quality?
Right. So some of these are when you read a study, what was in there, checklist. But you can also use them to plan a study. So you can say, well, this study is going to be evaluated according to these criteria, so it's input to how we design a study also. Good. Okay.
Can I just ask?
Yes?
Just regarding the general setup, but most of us work in a hospital setting. We don't have a centralized health technology assessment at a national level. So most of us are working in our own hospitals with our own P&T committees and so on. And often what we struggle with is to capture the, the indirect cost. Those are the things that we kind of struggle with. And we end up doing typically budget impact analysis. So I'm just wondering how we could best utilize these kind of tools where you have a fragmented approach where it's often difficult to know, or you have incomplete data to be able to input to get these kind of information, so you can present it to your administration,
right,
to be able to fund this particular treatment.
Okay, so some of that depends on what your economic perspective is. Are you representing the costs experienced by this hospital? And this hospital cares about the cost to it. It may or may not care about patient costs. Might not. Cost of transportation. That might be somebody else's problem. Or are you part of a healthcare system, and what are the costs accruing to the system more broadly? You might even be saying, we're representing the whole country, and we care about productivity in the workplace, right? And so, depending upon your economic perspective and the scope of that economic perspective, you may be including more or fewer of these elements in your cost analysis. There's no kind of single answer to that. Yes? I hope that's helpful.
Yeah, it's very interesting that sometimes we need to really address, like in asthma, absentees, and it's very important. But you cannot do it from the societal perspective. So this is the limitation between payers and societal perspective
Right.
studies.
And this is the problem we usually
Yeah,
So
it's
what-
very hard
in
to
a hospital setting.
apply societal in a hospital.
Well,
level.
but maybe you don't have to. Listen, it
Yeah.
has to, what is your mission? What is your mandate? And but declare it. In other words, the economic perspective is very important to specify, as I said before.
And I really, I'm very happy with, maybe it's not your business. This is very important thing that we have to address. That not societal perspective, maybe it's not the mission that we should focus on as a hospital level. And this is very important to see where you're addressing the studies and according to what your perspective. So thank you for
Please
the
declare.
word.
Yeah, you got to declare it.
Yeah, you have to declare it before you discuss it, even
Right.
with the higher administration.
And get it clarified with the ministry or whoever it is.
Yeah, and sometimes I can give one example quickly.
Uh-huh.
We had a new drug,
You know, a new drug.
a long time ago, 25 years ago, imatinib, that decreased, that changed the whole oncology.
It's an expensive drug.
The first, yeah, it was expensive at the time, and when it came to the market, actually the first article was Times
Mhm.
Journal. It's the first.
The change of
This is-
the landscape of the treatment of the cancer treatment. And when it came to societal perspective, the hospital actually raised the subject to the Ministry of Health that we need to treat those patients. And our patient and King Faisal used to get the medication paid by the ministry, not by the King Faisal. So this is the role of the maybe FTC that will see how important this to your population, either to expand the affordability, or raise the subject in a bigger level. So they dispense the medication King Faisal, but not from our budget, which is very interesting.
It's a difficult, again, this is how HTA has to be part of the real world.
Yeah.
Yeah. We have so many questions. I wonder, I may have to go a little over. Is that okay? Can I steal some time?
I don't think you can.
I can or cannot? Oh, okay, really? Because people have to go?
Yeah.
Okay.
I mean, there's just an hour break, so there's prayer and lunch, so.
So maybe, can I maybe steal a little time after lunch? Okay, we'll do that. Yeah, I just wanted to know how careful I need. Okay, so, because the questions are great, a lot of questions. Remember, when we talked about assessments, what do we look at? Technical, safety, efficacy, effectiveness, cost, blah, 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 blah. Organizational and systems, and then I'll show you LC and environmental. Organizational impact of a technology. Think about you have a new PET scanner at your hospital, or you have a clinical laboratory, or an expensive drug that requires certain ways to deliver it, and infusion services and different staff and so forth. What's the organizational impact is another impact of the A in assessment. What's assessed? Well, and this is a list I put together from other sources. I try to combine them. Health delivery process. These are the kinds of impacts that could happen. Does this change your workforce to have this technology? Does it change the clinical workflow or the administrative workflow? Do you have to reconfigure your site? If you're going to put in a new PET scanner, you need a new building. You need power sources. You need all kinds of things. So use of other products, data information, privacy, security. Here's the whole workforce issue. Not just who's involved, but how many people and what type. Education, scheduling. What are the economic impacts on your capital budgeting process? About implementation and maintenance, licensing, installation. Think of all the things that go into this. Structure of your healthcare system. Does a new technology call for a more centralized or decentralized health system? If you only have one PET scanner in the area, or one place to deliver a particularly physician-administered injected drug, blah, 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 or a gene therapy, is that going to have to be more centralized? Does it change the structure? Does it change anything about the society or community? Do you have to engage with your neighborhood or your community if you're going to add new buildings or new roads, for example? How acceptable is it? Community health, safety, and environmental footprint. Keep that in mind. Social inequalities or accessibility. So you could have, when you talk about potential organizational impacts, assessing these, it could be many, many things. Now, in most cases, only a few of these matter, but when you're in the HTA group, you've got to say which one of these could matter. So looking through a set like this might help you think, oh, we didn't think about that kind of potential impact. Okay. Ethical, legal, social implications. First of two slides. Technological innovation could challenge certain ethical, legal, social, cultural, religious, and other norms. In healthcare, here's some examples that we see have kind of challenged our ethical, legal, and social implications. Whole genome sequencing in newborns. Do you really want to have that information? If you get it, what do you want to do with it? Use of stem cells to grow new tissues. Procurement and allocation of organs and transplantations. Different countries and cultures have much different viewpoints of this. Cochlear implants for children, that was an interesting case. Life support for critically ill patients, certain AI-enabled technologies. What about testing in animals, preclinical testing? There's some ethical issues there. Methods of assessing LC, ethical, legal, social implications, have generally been underdeveloped, and relative to other methods in HTA, we need to do more work in regard involving different perspectives and how we assign values. Maybe we could use MCD in this, who knows? But life expectancy, quality of life, privacy, choice of care, how do we incorporate those different viewpoints on values? That's part of ethical, legal, and social. Furthermore, there are a variety of methods. We can't go into these today, but if you're saying, are there frameworks for examining potential ethical, legal, social implications? This is a nice kind of summary of various methods that have been used. Casuistry, coherence analysis, principalism, a more interactive approach, social shaping, something called wide reflective equilibrium. I'm not an expert in all these. I'm basically familiar with them. But they're all trying to do a similar thing, which is how do we get everyone's input on what's important to them for the LC? All right, quickly, evidence sources and search protocols in HTA. The sources of evidence, Matt, oh, did you question? Yes.
I just have a thought.
Yeah.
So someone said something about, like, there's so many new things to start considering in HTA that it's not possible. Like, so now the comment was like, now you're putting environmental issues, now you're putting like all of these issues, and like there might be like important, but they're not going to affect the final decision. So how do you not get distracted and maybe influenced by other issues that might not be very important?
Okay, so.
Time consuming, of course, to look into.
Oh, and time consuming and budget consuming and everything else. So one simple answer is, what's your mandate? What did the ministry tell you your job is? Okay, well, we can deal with that as well. What is your job? What are you supposed to do? And that might confine it. What I would suggest is that a priori you say, when we do HTA here, under what circumstances might environmental impact be important to us? So you might ask some initial questions. Is there going to be, does this technology release chemicals into the water? Does this technology potentially have nuclear radiation that might be exposed? Does this technology going to use up a lot of supplies and materials that would be wasteful? So you might ask at a very high level, is there a possibility of relevance here? Oftentimes there won't be. You'll say, this is going to have no organizational impact, or there's nothing about this that's going to have any large effect on the environment, okay? So you might have some a priori sort of guidelines about when or not to consider something. But it is not your job to consider every type of impact every time. You can't do it. You can't, unless you want to ask for a lot more money, more time. That's another issue. I see it's 12:30 now, so we probably need to break, and we'll come back. Well, why don't you tell people what we're going to do, and I want to steal some time when we come back. Is it okay?
So we'll come back 1:30, and we can then do like 15 minutes of what you want to capture.
Just some more other.
And then we can start with the example simulation session, where we'll break up into groups, and we'll have Dr. Ahmed leading one, Dr. leading one, Dr. Muhammad Ahmed leading one, and Dr. Ahmed leading one table. So we'll break up into that kind of groups, and then of course we'll have time to read through the study that we've chosen and kind of go through some of the concepts, and we'll have Dr. Goodman kind of go around and just like evoke some of the ideas, answer some of the questions that you find from your study.
Yeah, I hope that some of the things I've covered, I think you'll find useful. Yeah.
And then we're hoping that every table maybe has a kind of what they would do and why. But it's not an endorsement to or for or against the drug because it's kind of a new drug. Yeah, so can we just take a group photo before lunch? So we don't please, if everybody can.
And thank you for your usual support. Thank you. Thanks. يا على حسب هذه. جانسون اند جانسون. شكرا دكتور يعطيك العافيه. ميراني جروب. مينارين جروب. لا هم برا اعتقد يا جين فارما please. I think they're outside anyways yeah of course الحكمة أهلا وسهلا. Yes. Thank you so much doctor for your support. Thank you. Thank you so much. Go enjoy your lunch. I'll be downstairs and